Media for their support of this project. Pope Francis has been known for talking about two things, well, talking about a lot of things, actually, but two things in particular that guided our approach, our editorial approach to this issue. The first, the importance of seeing the person who is the subject of all of our public policy questions. Not an abstraction, not a social construct, not a statistic, certainly not a problem, but a person, to see the person at the center. And also to go to the margins, that the church is called to the intersection of the church and the world, and it is called there to help to empower those who are disempowered and to ensure that every voice is heard and that the inherent dignity of every human person is respected. So these were the twin principles that informed our editorial approach to this magazine. I should say that our moderator tonight, Kerry Weber, was the one who helped really to organize the content for this issue. And I'm very proud of her work as well. And grateful that you'll have an opportunity to hear from her. So without further ado, thank you. Welcome to America Media. And it is now my pleasure to introduce to you Mario Paredes, the CEO of SOMOS.
Dear friends, Father Malone, President and Editor-in-Chief of America Media, distinguished panelists, ladies and gentlemen, good evening. As CEO of SOMOS Community Care, I have the privilege of offering you few reflections before Ms. Kerry Weber, Executive Editor of America Media, introduce this evening distinguished panelists. Tonight's occasion marks the publication of a special issue of America Magazine that is wholly dedicated to healthcare on the margins, signaling the urgent task of finding cost-effective, sustainable way to provide quality healthcare to our country's most vulnerable patients. Such is the mission of SOMOS, and therefore we are proud to join America Media as a sponsor of tonight's panel discussion, and we are thankful for the opportunity to have helped produce the June 10 issue of America. The push for reform of publicly funded health care so that government can optimally fulfill its obligation to serve the poor has been the hallmark of the life and work of my boss, Dr. Ramon Tallaj, the founder and chairman of SOMOS. I recall that President Obama invited Dr. Tallaj to the White House on several occasions and relied on his expertise in the development of Affordable Care Act. It is a far from perfect piece of legislation, but nonetheless a major step forward as it gave millions of uninsured Americans access to health care. The act provided extra Medicaid funding to the state, which prompted New York Governor Andrew Cuomo to greenlight the Delivery System Reform Incentive Payment Program that pegs payment for doctors to the longer-term health outcome of patients. The greater their human flourishing, the greater the payment for providers. That is the heart of value-based care. District offer an alternative to the waste and corruption-prone traditional Medicaid formula that pay doctor on a transactional basis. District gave birth to SOMOS, which gave Dr. Tallaj the opportunity to deepen his exploration of the role of the primary care physician, which he deems crucial for the success of healthcare reform efforts. SOMOS has demonstrated great success in providing more than 700,000 of the most vulnerable Medicaid patients in New York City with quality care, keeping them out of emergency rooms and costly hospital beds. The SOMOS District value-based care model holds significant promise. Its record helps make the case for a tweaking of the Affordable Care Act, not its wholesale dismantling. SOMOS will continue to be an advocate for government to put innovation at the service of its responsibility to meet the needs of the poor, physical, behavioral, and social. Dear friends, I wish you all an informative and inspiring evening. Thank you for listening.
Thank you very much, Sir Mario. My name is Kerry Weber. I'm an executive editor here at America Media, and I am very honored tonight to be here with these wonderful panelists. And I will waste no time in introducing them so we can get to hear some of their perspectives on this issue. So immediately to my left is Dr. Ramon Tallaj. He's the chairman of the board of SOMOS Community Care, which he founded in 2015 as the only physician-led performance provider system participating in New York State's Delivery System Reform Incentive Payment Program. Dr. Tallaj oversees the SOMOS network of nearly 3,500 healthcare providers and over 650,000 patients from largely underserved communities across New York City, including many Asian and Hispanic immigrants. He's led numerous healthcare missions to the Caribbean over the course of his career, including most recently a delegation of SOMOS bilingual network physicians and specialists from New York to Puerto Rico in the immediate aftermath of Hurricane Maria. Dr. Jonathan Giftos is the clinical director of substance use treatment for the Division of Correctional Health Services at Rikers Island, where he oversees diversion, harm reduction, treatment, and reentry services for incarcerated patients with substance use disorders. He's also the medical director of the Opioid Treatment Program for the NYC jail system, in which he provides clinical care to incarcerated patients with opioid use disorders. Prior to this, he was the director of clinical education for CHS, where he developed curriculum, provided clinical supervision, and supported the educational goals of med students, residents, and attending physicians caring for patients affected by the criminal justice system. And the Reverend Myles Sheehan has served as superior of the New England province of Jesuits. And from 1991 to 95, he was an instructor of medicine at Harvard Medical School, an attending physician and director of geriatric consultation services at Beth Israel Hospital. In 1995, he moved to Loyola University Medical Center in Maywood, Illinois, and his activities at Loyola University include administrative, teaching, curricular development, and work in his role as a senior associate dean and director of the Ralph P. Leshner Jr. Institute for Medical Education. He currently serves as the provincial delegate for Senior Jesuits for the Maryland and Northeast provinces of the Society of Jesus. So thank you all very much for being with us tonight. And I want to add that during this evening, you are welcome to fill out our survey that you can enter in questions or your thoughts and opinions at americamag.org/health. You can do this while you're following along from home on our website or comment on our live stream. or through social media. There'll also be a chance for folks here to participate in the live Q&A following the comments from our speakers. So without further ado, let's get started. So each of you works in your own way in healthcare at the margins. But I wonder if you can share with us, just in a couple of sentences, what that looks like for each of you on a day-to-day basis. What does that actually mean for what you do when you wake up and you go to work in the morning? Dr. Tallaj, would you start?
Well, from the point of view of administration, is different than what I was seeing patients. Then see, I represent this amount of physicians, more than 2,000 physicians. I want to tell you what it looked like for them. Because most of the time, the people who make decisions in our communities how to do some kind of changes are people who never been one of them. They are very well accredited people, but they never been smelled one of our Medicaid patients in our community. This is the way it happens, you know. Before you know, we, close to 2,000 physicians, we see close to 45,000 patients every day. I could tell you that in 1 week, we could see what, in 6 months, all the hospitals together in New York City. And these are not people who have resources. These are Medicaid recipients who qualify because they are in poor condition. Social determinants of, it's clearly that economic stability is the most important issue there, where we had to day by day work. And I will tell you, thank you to this RIP, we were able now to change the way that we see medicine. It used to be a transaction, as Mario said earlier, where we got a fee, see the patients, take the medication. We had no idea what happened to the patient. Later on now, we have a holistic way to see the patients. We work with the CBOs in the community. We have all the computers talking to each other. We avoid duplication of services. We know what happened to our patient 24/7. We have a team of people doing that is able to even go and find the patient when they don't show up, whatever it is, sitting there at home. It's a different game now because I could know exactly what happened to my patients, any social problem, any housing problem, any economical problem who could affect what happened there. We now are in contact with, we have a team to overlook. This happened when the Medicare redesign team, the Governor Cuomo create, help us to have the resources to do that. And the typical day is that. We got end of the day, but now we have the help. We didn't have this help. Now we have the SOMOS people all over. You could, as I said before, it could be housing or anything, any issue that happened in the community. It's very important to understand. I don't know if you got to answer your question, but to the point that we were able to do in a study in our community, come from the same people in the community, 600 patients, 200 doctors, where it clearly showed the difference. And I will speak to you later on because it will be very important to let you know what happened there.
Thank you very much. Dr. Giftos.
Hi, good evening, everybody. So I work for New York City Health and Hospitals Division of Correctional Health Services, which is a division of the city's public hospital system that provides medical services in the New York City jail system for people who are incarcerated there. And I see patients, and I also oversee a lot of services to try to reduce the harms of incarceration for people who are in the jail system. We have, unfortunately, in the United States, some of the highest rates of incarceration in the world, and we know that it's a risk factor for a lot of negative health outcomes. And so a lot of our work on the health side is trying to intervene upon some of those risks and reduce those harms for people. So we do comprehensive medical intakes as people arrive in the jail system. We treat withdrawal symptoms that people may have if they're using certain substances. We diagnose HIV and hepatitis C, and we initiate treatment for people. And we also assess people with decompensated mental illness and refer into services. All of this is really with the goal of reducing harm, but so much of what we do is also just bearing witness, to people who are suffering through some of the hardest days of their lives, and being a warm kind of non-judgmental presence for people that they can talk to about their experience, and then we can, often through collaboration with other parts of the health service, advocate for patients as they sort of navigate their legal case.
Thank you very much. Dr. Sheehan.
Currently, Currently, what I do is supervise the care for Jesuits in 4 healthcare facilities on the East Coast. So I have about 200 Jesuits. I do not practice medicine anymore. When I became the Provincial, I couldn't do both at the same time. And so in a certain sense, people talk about Jesuits being on the margins. The men who I see are older Jesuits who are on the margin of eternal life. And perhaps to say what my clinical practice, though, was like, to speak to some of the things Dr. Tallaj did, I did geriatrics, focusing on, obviously, older people with cognitive disorders frequently. So I worked a lot with people with Alzheimer's disease or other cognitive disorders. But within that, I also did a lot of palliative care. And academically, a lot of my work was discussing palliative care within the Roman Catholic tradition. And so the margins that I would talk about are the margins of life, the margins where people are old, they are facing the end of life, they are facing life-limiting illnesses. And the struggle in those situations was to provide care that was merciful, that was clinically good, and that let the people feel that they were valued as an individual, even if they might not remember their phone number, but they certainly knew their value as a person and the ability to care for them in those ways. With the privilege of also being a priest, with many of my patients for whom I did palliative care, I did their funerals. And that was another way to sort of work with people going from one margin into something far better. And working with those people, older people, so often they would say, please don't let me go to the hospital. And being able to assist them with pain and symptom control, never to kill them, but also to make sure that they were not abused by the medical system at the end of life. Those were the things that I found great joy in, and I miss that.
Can you talk a little bit? I imagine the conversations around the aging process can be especially delicate and difficult, and death and dying as well. Can you talk about the ways in which your training as a Jesuit influenced your perspective on those conversations and what that brought to it?
You know, I was trained as a physician first, and so I think that my training as a Jesuit perhaps made me more open to listening to some of the spiritual issues. But the other part, working with older people, they're not fragile. And I think often we dance around so many conditions, so many discussions. You know, somebody in their 90s knows that, you know, their time in life is coming to an end. And if they don't, they're incredibly narcissistic and are going to be difficult to work with otherwise. So, you know, it was relatively easy to say, what would you like if you'd be cared for? And then the other time with people, particularly folks who not unreasonably would be pushing the issue of the care that they wanted off to the side, you say, you know, what do you want first? They go, I want a cure. And I go, if I can't give you a cure, what is the most important thing for you? And that's when you'd often hit pay dirt in terms of some of the spiritual issues and things like that.
Thank you. Dr. Giftos, the population that you work with deals with a couple forms of marginalization, right? They're incarcerated, they are struggling with addiction, and even when you're struggling with addiction, there's sometimes a stigma that goes with overcoming addiction with the help of medicine. How do you help sort of treat all of those things? Where do you start with that when you're thinking about trying to prepare someone who is struggling with all those things in a contained environment, and then who is expected to then go out and live in the world without any of the help that you provide necessarily?
Yeah, that's a great question. We talk a lot about stigma in the work that I do, which is really the systematic disenfranchisement and marginalization of people away from services because of something, some characteristic that they have. And we see people who use drugs or people who struggle with addiction and people who are involved in the criminal justice system as having two big reasons that they're stigmatized against. And so I think that there's a couple ways to address that. One is by sort of reaffirming the inherent value of every person that I talk to, and sort of reminding people that I believe, that I care about them, that their life matters, and that the system, that we as healthcare providers care about their life and that their life matters. But also kind of looking internally as a system, as a healthcare system, at the ways that we stigmatize the very people that we hope to serve. And I think that we, specifically around people who are justice involved or criminal justice involved, there's a lot of work we've been doing in the community to try to make the healthcare setting more friendly to people with a criminal justice history. A big piece of that is acknowledging trauma and the role of trauma in people's lives. And for many of my patients who have definitely seen and witnessed violence, a big form of trauma for them is actually abandonment and neglect. And when they encounter a healthcare system that does not welcome them with open arms, but that may be neglecting them or abandoning them, that can be very challenging. And so trying to build warmer, more inclusive care environments is really important to address some of the harms.
Thank you. Dr. Tallaj, one of the goals of SOMOS is to help make sure that people are getting ongoing care for chronic conditions rather than trying to treat them when they get to the point where you need to go to the emergency room. What is the first step in helping people to recognize that need for ongoing care? And how do you help people to take that step?
Well, the most important is what we have done is to be sure that the family, the community, the doctors of the neighborhood is important. It's something that we were used to say that are kind of services. Yeah, somebody else in the team who does services. No. The physician, this important person that people trust. How do you work with them and be an institution? And then working together, we're able to create, for example, we had an institution called Rapid Care Solution. We call it 1-800-RAPIDOS is the phone number, where we go to the patient's houses. We don't expect the patient to go to the emergency room. We had all the doctors instructed and our computer system connected to be sure that we're able to intervene this patient before he get to the full-blown to need to go to the emergency room. And then it's not 100%, but when you have a successful, you have 39% reduction in admissions, avoidable admissions, and 34% avoidable ER visits, it tells you that something is going on there, and that's the saving that the system needs. At the same time, it's better care. But if you focus different before that chronicity, how do we work with the prevention? If we don't do the service that we need to do now, today, on prevention, the people who love to continue fee-for-service transaction will love prevention not to be there, because it continues feeding that places that they want to have a transaction. Well, if you are working with a lot of prevention in the communities, all these community people are going to go in growing up in better shape. And I got a lot of examples that I could give you. For example, vaccinations, that we all know what big things happened lately in New York City. And whatever the situation happened, we look right away within our community to see what's going to happen. And thank God, so far, we haven't had one case. And because we be sure that that prevention with the vaccination and education, our people, is there. Now, with this report that I was mentioning earlier, we'll be able to intervene even further. Which patients are the ones who would need? I'll give you some of the findings. Translation. Sometimes elderly people go to the hospital or to places there's no translation, and then you could use whatever. You don't have a professional or somebody who knows exactly. You could make a decision in the healthcare decision who will affect the patient negatively. And for example, in the Bronx, only 10% of the healthcare workers in the Bronx speak Spanish, while 65% of the population do so. Specialists, I'll tell you that it's probably a couple of orthopedic doctors who are Hispanic, who like to work in our community. Well, we have thousands and thousands of patients. Well, we've been working with those results to the authority to say, no, you are the one giving money to this hospital. They need to start choosing people who want to work in our community who speak the language. 1 of each 6 people, 8 people in New York City is Hispanic. We only had 2 orthopedic. if you do so? How can you handle that?
Thank you very much. Dr. Sheehan, I wonder if you could talk a bit about what are some of the important conversations that people can be having when they're young to sort of think about what to do when as they're aging, and conversations that maybe people could start earlier to think about this in a healthy way before it gets to the point of fear.
Two things. I think one is they can bring it up with their parents, because often that's part of the barrier, that the folks don't want to talk to the kids, or the kids don't want to talk to the folks. And, as I used to say, if you have two children and you haven't made out an advance directive, you're going to have a fight in the ICU, and so you need to get that settled. I think the other part for younger people, when I would work with my medical students about advanced directives, and I was like 50, they all thought, well, perhaps I should never be resuscitated and not have any care because I was obviously so old. It was a waste of money at that point. I think part of it is being realistic, that your degrees of what is a good life change, and people have an understanding for that. So I think it's to be open. What I'd say for younger people, you want to have acutely reversible illnesses treated very aggressively when you're young. If you have a chronic illness, again, there's plenty of things that could be done, but you want to talk there about burdens and benefits. The worst thing I think you can do is I think the most important thing you can do is to make sure you have an advance directive, or in Massachusetts it's called a healthcare proxy, but they're basically the same thing, where there's someone who knows you and your values well. And I mean, when I would have the conversation with my older patients, occasionally older people can become acutely ill very quickly and decompensate, and they also can get better relatively fast. So I'd say, I need somebody to talk to, because if you look really sick, I would like 24 hours to figure out what's going on, to see if you get better. And then 3 or 4 days later, if you're not getting better or getting worse, to say that's enough. And people would feel happy about saying, oh, there's going to be a doctor and someone I care about, who everything isn't automatic. I don't like those advance directive forms that click off boxes, no dialysis of this, no that. It's like, and I don't mean this in an offensive way, healthcare is not like choosing at a Chinese restaurant. You need to have people there who are knowledgeable about what can happen with reversible illness in the elderly, but also knowledgeable about who you are as a person and what your values are.
Thank you very much. Dr. Giftos, are there any conversations going on between the world you're working in incarcerated populations, and the broader medical community about opioid abuse and how to help prevent people from getting to the point where your patients are, and that connection between the incarceration and drug use, and are you learning things on the outside that can be applied on the inside and vice versa?
Yeah, so I'm an internist by training and an HIV specialist, but most of my clinical work more recently has been in caring for people who have something called an opioid use disorder or opioid addiction. And when you talk about opioids these days, you think, prescription pills, right? That's sort of what you hear on the media. And that narrative actually is only partially true. Because there's been a lot more attention paid to opioids when it started to affect whiter, suburban, more well-to-do communities. But the reality is that opioids include heroin, and that communities of color, low-income communities of color in New York, have struggled with opioid use and opioid use disorder for many, many years. They've been incarcerating people who struggle with opioid use and opioid use disorder for many, many years in the jail system. So in some ways, it's not a new challenge. It's just affecting additional parts of our community. And so I think it's really important to say that the attention paid to this epidemic is in part due to the fact that it's affecting a different population of people. And that people who use opioids historically would often use heroin. and that people who use heroin often do so for sometimes very practical reasons. It's not always this sort of nefarious kind of path into drug use. A lot of people use opioids because it helps them manage pain, it may help them manage anxiety, it may help them manage some stress. And that the challenge with opioids in general is that for some people, chronic exposure to opioids over time builds up your tolerance to opioids, and you need more and more of an opioid to feel the same way. And that if you don't use an opioid, you feel really sick. And you feel so sick that it drives people to do all sorts of things to acquire more opioids, and that puts them at extremely high risk of criminal justice exposure. So I would just say that, to make the point that the empathy that we bring to people who have been affected by the prescription opioid crisis, if we could bring that same empathy to all people who have used opioids and struggle with opioid use disorder, I think that we would start to have more humane criminal justice policy, more humane healthcare policy, and that we would do a lot more to reduce the harms of that challenging diagnosis.
Thank you. Dr. Tallaj, you work at SOMOS with several immigrant populations. I wonder if you could comment on whether the current political climate around immigration impacts the ability or willingness of the populations you serve to receive or seek out appropriate medical care.
Well, I will tell you that from the beginning, let me give some points is very important to know. We create SOMOS Familia. I got Ricardo here in the audience. SOMOS Familia, which is 1,000 kids from the border who were sent to New York. And we immediately joined the task force who was doing that, and we are taking care of all our physicians voluntarily, no payments. Sometimes they will get Medicaid and get approved for that, but we voluntarily start working with those kids from the border that the family is somewhere else, and they're here in some custody in some foster care, and we are the one taking care of them. That's one piece. The other thing is, I would say probably 95% of the people that we are immigrants. Most of the physicians that we care, we speak for Arabic, Tagalog, Russian, Chinese, and Hispanic, obviously Espanol. But most of the people that we take care are immigrants in our community, poor people who came to work, who is difficult to get out of poverty, different generations, and we don't stop because of that, and independently of the status of way of payments. We've been doing that before this RIP. We work on this RIP. He helped us more resources to do that, and able to accelerate some processes to deal with them, but we will never stop. It's anything in the Middle East, I could tell you that the people without papers, as I call it, because that's all. Still the human beings with the same needs, same diseases. When you hear somebody saying that you will not take care of them in the emergency room and say, Jesus Christ, the virus doesn't have any wall. The virus will pass any wall, and we were contaminated. You have to take care of them. You cannot try to turn your face to say that you don't take care of them. They will have to find something. We must, because of the way we put the whole population at risk. We don't care about the status. We just take care of them as a human beings who need some services that we have the grace of God to be able to be the one having the study and have the knowledge to take care of them.
Thank you. A quick reminder for anyone watching at home or anyone here, if you want to fill out our survey at americamag.org/health, you can add in questions for our panelists and give your own thoughts on healthcare in the United States. So now I have a question for all three of you, one question. It connects to what Father Matt Malone mentioned earlier about seeing the person, although we did not intentionally coordinate this. We're just one mind here. I think for many people, it's easy to see the populations you serve as a series of statistics or as one large group, rather than to see the person, as Pope Francis urges us. I wonder if each of you could give us the story of one individual whose life or an experience that they've had sort of represents some of the main challenges facing that population, and something that's really stuck with you and moved you. Anyone of you may start.
Elderly lady, in her late 90s, lived at home, obviously, with her son and daughter-in-law. She actually had bad rheumatic heart disease. Obviously not that bad. She made it to her late 90s. But she had a variety of valvular problems, including the valve on the right side of the heart. The tricuspid valve was wide open, so she had lots of problems with edema and all those things. And she wouldn't come to the office, and so I used to spend about an hour with her every week. First, people would say, aren't you wasting so much time with that? And I would find often that when she called, I knew exactly what was going on because I knew her story, and I knew her house. And once I ended up admitting her to the hospital because she had cellulitis. Her leg had a superficial infection because it was so swollen. So within 24 hours, she said, you get me out of here. And so I said, well, I might not be able to treat it at home. And she goes, that's fine. Get me out of here. So I learned a lot from her, and we became very good friends. Sat with her while she was dying and then buried her. One of the things that's all through these stories that comes up there are these buzzwords that are not buzzwords, they're good words in Catholic social teaching. Human dignity and solidarity. I mean, that's what I hear with John and Dr. Tallaj speaking about. John was my medical student, so with the human dignity part, recognizing the worth of the individual, which is why you're talking about these stories, and then the other part, the solidarity, the stuff that SOMOS is solidarity in action, caring for people so that we create a society where people are valued because of who they are.
I would like to do one story of 4 of them. I'll start with Puerto Rico. We went to Puerto Rico probably a couple of weeks after the disaster because we went in the symposium in Vegas, a large group of doctors, close to 600 doctors. And we went there, we know what to see. But we went to the mountains. We see all the resources were in the city. We went to a place called Comerío and Naranjito. But you know what? They have a lot of people with diabetes, but there was no electricity. Then the insulin don't work. The insulin is going to get damaged. We brought some of those solar panels to get some energy and put the insulin into part of the city. People could deposit there and come back to get it every day. And I still believe that almost like probably 4 months ago is when they got electricity. And they start to rely on those things. That's one crazy thing to say it for an American citizen living in the island called Puerto Rico, that at some point they had no way, people would have died from diabetes, we had no insulin because they don't produce the insulin. That's one story. I'll give you a second story. It's a young girl who had 28 years old cancer of the breast, and she had Medicaid. And there was a threat in it, in this administration, to take away the Medicaid, or the, what do you call that, the Affordable Care Act, some changes that will affect her. She came to see us, she cried and said, what am I going to do? I cannot afford to pay for this. And this is very expensive. And a lot of young people are like that. They depend, and they supplement insurance. There's no Medicaid alone. The one had a little bit about poverty, that they threatened to take out the subsidies. That would be a disaster because she won't be seen by anybody. Because then the cost of the care will be. The third case is very everyday case that I could tell you right now. Everyday case is Maria Ramirez. Let's say she had diabetes. She normally comes to my office and she has Medicaid. Now Maria Ramirez disappeared. I don't see her for the last, she's supposed to come, she didn't come. Or she was sick. She got some problems. Well, finally we find out she went to the emergency room, deteriorated. Her health is bad shape. Why didn't you come to see me? Dr. Tallaj, I had to pay $3. The copay, I don't have it. This is why I didn't show up. Yes, $3. I'm saying $3 to everyone here. $3 the rice and bean and the plantain or the eggs for the day. She had to decide, should I pay for this? I've been talking to the presidents about that. It's mandatory for us to request it. They don't have to pay. They don't have. We could wait that. We must ask for that money. Otherwise, we are against the law. That which you upright or lost. Since story like this, I give you a few. People don't see it because it's not. And the last one, it come to me since that we take for granted. Anybody here, raise your hand, whoever does not know who your primary care is. Who you do not know. Anybody here does not know, you know your primary care?
I do.
Did you choose it? Did you choose? It's good to say that. Did you imagine you have a system that the government want to choose your primary care for your kids in the school, for example, school-based clinics, or, in any direction? And this is very important. We take it for granted that we were able to choose the doctor for you, for your kids, and for your family members. We shouldn't lose that. This is the kind of story that I could let you handle that. A few glimpses that we see, or you call it Puerto Rico, you call it El Barrio, you call it Washington Heights, South of the Bronx. It's happening every single day.
There's a lot of, you work in a place like Rikers Island, you have lots of stories, and I try to be really careful about telling stories about patients because I want to respect their kind of their own right to tell their own story, and not to exploit them, but I care for some category. I kind of speak a little more generally about people, and I care for a lot of people who. When I sit down in the clinic and I see that I'm about to see a patient, I'll open their chart and I'll see their photo pop up. And very often I'll see, somebody look, it's the photo they took when they arrived in the jail. They look tired. They may have tattoos all over their face. They maybe have a sort of a menacing kind of look because they're not happy to have their photo taken in jail. And I'll say to myself, like, oh, well, this is going to be an interesting visit. Who's this patient I'm about to see? And almost without fail, the person that sits down next to me and starts talking to me is so much more than their photo. I had a patient once who had like a lot of tattoos on his face, and he had a stutter. And he comes into me and he tries telling me through his stutter that he wants to get his tattoos taken off of his face because he was 10 or 12 years old in Puerto Rico and he had them done while he was in juvenile prison, and that everyone just looks at him like he's a bad person because of his face tattoos. And I was thinking to myself, this person has heroin addiction. I'm going to treat that's the easy part for me to treat. We use methadone and buprenorphine, which are really effective medications. But how do I help this guy get the tattoos off his face? That's what he wants. That's what he wanted to talk to me about. And I didn't have great answers in that moment. But just to say, there's another story just like that where I was, seeing a patient in the clinic and they brought him down in something called enhanced restraints, which is where they have to have their hands behind their back and their ankles are shackled together and they have sometimes like a mask over their face so that they can't spit at you. And he comes into the exam room and they take all these things off and we just start talking. And I'm like, why is this guy coming down here like that? 2 months later, I'm at a community event in the Bronx, and I see him in the community training people on how to reverse an overdose with naloxone. And he yells at me from across he's like, Dr. Giftos, Dr. Giftos. And I come over and he was so proud that I saw him doing something for his community when the last time I had seen him, he had a face mask on and his hands behind his back. And he ended up inviting me to meet his wife and his new baby daughter. And so the way that the criminal justice system sometimes can sort of, turn people into monsters and imagine them to be monsters, and then they start to imagine themselves as monsters, and it really has this sort of dangerous kind of cycle. And that when we can kind of see people underneath that veneer for who they really are, there's really powerful moments of connection. And I've seen really amazing transformations happen. But we need more spaces where people can be seen for more than maybe the hardened external, appearance.
Thank you. Are there any lessons that you've learned, or maybe one lesson from your work in healthcare on the margins that you think actually could be applied to the larger healthcare system, things that might be missed by the broader swath of healthcare providers that you have unique insights in because of the work that you do?
I think Dr. Tallaj and John have mentioned this in other ways. There's a thing that we do in geriatrics where we do check out somebody's functional status. In other words, with an older person, I can have two 90-year-old patients, and one is really in a desperate shape, and the other is just fine. And so what do? Can they get up? Can they go to the toilet? Can they take a shower? Can they get dressed? Can they feed themselves? And then can they use the phone? Can they figure out public transportation? Blah, blah, blah. The part that both John and Dr. Tallaj said, it's a way to figure out what the person is really like rather than simply focusing on a list of medical problems. And it's a way to lead to a deeper conversation about the person. People will say, oh, that takes so long. It doesn't take long. And it actually makes it much quicker and efficient as the time goes on. So trying to gain the context of a person's life, to look at the person. You know, there's a thing that in Jesuit spirituality, if you're on the retreat, people will say, when Jesus looked at the blind man, what do you think that gaze was like? And I guess there's Foucault talks about the clinical gaze too a lot. You know, what is that? Is it a gaze that objectifies, or is it a gaze that promotes solidarity, recognizing the dignity of the person in front of you? And there are practical ways to do it. Like you find out what the heck's going on with your patient. You know, you are careful with the physical exam. You ask them what's the most important thing that they want done that day. Those are not rocket science things, but they make a big difference.
Well, healthcare definitely did not start with a big building. You call a magician, the beginning, whatever you want to call it. They were the one giving powders, singing around. There was a relation between one human being who finds some way to give some kind of whatever kind of treatment, and then they call that guy a physician. Then he needs for so many people that he needs some help. They call a nurse. Then so many, now they need a place, they call it a clinic or whatever you're going to call it. But you didn't start for the building. Healthcare is about that relationship that's lost. We're trying to come back to that relation between the person and the other person, to trying to heal, prevent, do things. And this is the way that I see healthcare should happen. The resources should be put in that direction because we spend so much money in the buildings. And then, because I know I don't want to say that because I don't want to get into that detail who control that. But that's what the problem is all about. And I don't want to close without saying one story who made you laugh. I have a 90-year-old lady coming to my office with the 3 daughters, which are 60s. And they come say she was very upset at this order. Because the daughter said, she's not following any diet, she's eating everything she wants. And the 3 of them sit, there's 4 chairs in front of me. And I took out from my chair behind the desk, I went to where she's sitting, the lady, pulled her up, sit there on my chairs. I went and sit down to the side. I said, would you mind tell us what you're doing? Because it must be very good. You're 98. We are not. Yeah. Whatever you're eating, it must be very good. That's it.
Okay, I didn't want. I wanted to make sure you finished that one. I think that the biggest lesson I've learned in caring for people who struggle with addiction and who are caught up in the criminal justice system is really to meet, to Father Sheehan's point, to meet people where they are, to find out what's important to them, and to partner with them to sort of work through whatever goals they may have. Too often in healthcare, we learn all about what other people should be doing. We think we have all the answers for people, and we can be very paternalistic and instructive. Most people, after you've told them 20 things they should do, walk out and don't remember any of it or are put off by it. And what I found really is that even people who are injecting drugs in their neck under a bridge in the South Bronx may and often have goals for themselves, and that if you respect them and respect what their goals are, you can make and partner, you can do some really great things. And I think we too often rush to sort of make our own decisions about what's best for people. And I think we would really do best to meet people where they are.
Thank you. And thank you very much to all three of you. We really appreciate your insights this evening. We'd like to open it up to questions here in the audience and also online. Yes, sir.
Put it right here.
Quick question for Dr. Giftos. When you were talking specifically about what's going on with CHS and the issues surrounding opioids, I'm wondering if you could also address the issue of fentanyl and also K2, please.
That's interesting. Yeah, great question. Fentanyl is a little easier to talk about. Fentanyl is many of you may have heard about it. It's a synthetic opioid that has been used for pain control for a long time by doctors and by anesthesiologists. But the fentanyl that you may hear about in the news right now is illicit synthetic fentanyl that's made overseas and that's folded into heroin to make heroin more potent and cheaper. And that has created a really unpredictable drug supply in New York. So people who use heroin, and they may have been using the same amount for a long time, may use heroin that's contaminated with fentanyl. And it's led to a tripling of the overdose rate in New York over the last several years. And so we have universal kind of counseling around the risks of fentanyl. But just to make sure everybody knows, it's not the fentanyl that you might have seen used by doctors, fentanyl patches, or fentanyl used by an anesthesiologist. It's an illicit fentanyl that's cut into the heroin supply. So the drug supply right now is as dangerous as it's ever been for people, and that's what's led to dramatic increases in death risk from opioid use disorder. K2 is synthetic cannabis or synthetic marijuana, and it's a really heterogeneous product that people can smoke. It has a risk mostly because it's so different and no one really quite knows what they're using when they use. But the primary driver of K2 use, or at least a major driver, is that you can't check for it on a urine drug screen. So if people are under a lot of surveillance from whatever system is overseeing them, either the criminal justice system or or others, they may be trying to use something that can't be detected, and it's associated with the biggest risk from smoking K2 really is acute psychosis. It can cause people to experience the symptoms of a psychotic break, and they may end up in the emergency room for symptoms that that can be scary and dangerous for people. Yeah.
Thank you. Other questions in the audience? Yes, Bill.
This is actually for Father Sheehan and for Dr. Giftos, perhaps for both of you. I'm very interested in the intersection between science and spirituality. And I don't know if you're aware, Dr. Giftos, but in Richmond, Virginia, the McShin Foundation has started a revolutionary program with inmates when they realized that way north of 50% of the inmates were addicted to either alcohol or drugs. And John Shinholzer there said, these guys don't need incarceration, these guys need some recovery. And they started a very intensive program, forming community, first of all, among those inmates that were addicted, which was, as I say, north of 50%, doing 12-step work with them, but also holding them accountable with discipline, et cetera. And it significantly reduced the the recidivism rate by more than 20%. And I'm curious, how perhaps at Rikers Island, are there any programs like that, and have you seen any sort of similar work by treating people more from a spiritual basis?
You know, it's a great question, and it's a little bit controversial within the addiction world, this idea that, we want people to think of addiction as a health issue, but with most other health issues, we don't often invoke spiritual solutions, right? And so at the same time, we recognize that for many people, their form of support, their form of community can involve spiritual, communities. And so I think that what we often will do when we care for people who struggle with addiction is say, here's the treatments that are sort of more focused in a traditional biomedicine intervention. And we know that for opioid use disorder, methadone and buprenorphine are really the only two interventions that have reduced mortality for people with an opioid use disorder. These are maintenance medications that people can take for a period of time. But that the context for those treatments may involve recovery support that is informed by or that is part of either a faith-based community or another recovery community. And that often provides a lot of support for people as they're managing to change and to sort of pick up the pieces that maybe have been destroyed through the process of their addiction. And so I always talk to people, I'm careful not to invoke spirituality if that's not the person's language, right? If that's not something that they, but I ask them, where do you go for support? Who supported you? Where do you find community? And if it is if it is rooted in something spiritual, I'm very supportive of that. And I think that we try to be careful about it, but we know that it's very helpful for many, many people.
And I mean, just a quick follow-up. I think when you take care of people with chronic illnesses, which you often do in geriatrics, is when I say, I can't cure you. We can work together to try to maintain your functional status and recognizing the problems with the term quality of life and your quality of life. But what keeps you going? What's the most important thing for you? And then to be able to talk about that, and particularly with issues of folks with abuse, substance abuse and things who've had traumatic backgrounds. I just work really hard to make sure people didn't feel bad. I mean, in the early days when I was a resident taking care of people with HIV, does God hate me? Am I going to go to hell? No, that kind of thing, to make sure that people don't see that their human dignity is negated by the fact that maybe they do drink too much. Maybe they do take drugs. They're still a child of God and loved that way. And I think that's sort of an essential part of a full recovery. And for people with a chronic illness who you're not going to cure, to know that they're still cared for, that they can be healed even if they can't be cured.
Hello, my name is Wally Rodier. I'm coming to you from Levittown, Long Island. I've been working in prison ministry for a number of years, and one of the difficulties has been addiction in the jail. And about 4 years ago or so, I was trying to find out what can I find out about the opioid crisis. It turned out that my own parish of St. Bernard's in Levittown has been hosting for every Tuesday night a meeting called Vivitrol Education and Support, which of course, as you know, is a medical assisted treatment. As an antagonist, a non-addictive antagonist, what place do you see, Dr. Giftos, for the use of Vivitrol in the whole recovery process?
Yeah, that's a great question. So you may have heard the treatment of opioid use disorder. You may have heard of 3 medications commonly used: methadone, buprenorphine, which is Suboxone, and Vivitrol, which is the brand name for an antagonist called naltrexone. They're all better than nothing, right? So they're all effective in their own way. The data to support methadone and buprenorphine is older and stronger, specifically around mortality reduction. The biggest risk of overdose for somebody with an opioid use disorder is when you detox them off of opioids, they lose their tolerance for opioids, but they remain with strong cravings. And so they relapse opioid use in a setting of reduced tolerance. The overdose death risk is really high. So naltrexone is a shot that requires somebody to first be fully detoxed off opioids, and then they get the shot. It lasts for 28 days. But if they don't get another shot, which is what unfortunately the data shows, that few people continue to get another shot, they're left in a really vulnerable abstinent state. And so the risk of relapse and death is thought to be a little higher. So I generally think of methadone and buprenorphine as first line for severe opioid addiction. But if you're not interested in taking a medication like that every day, or if you've tried it and it hasn't worked, or if you're strongly motivated to try something different, then I will support people with a naltrexone or Vivitrol shot. But generally, the literature doesn't suggest it to be first line, but that for a subset of people, it may be effective. Just one more piece about that. They did 300 people entering the Rhode Island correctional setting with opioid addiction were offered all 3 medications, and 4 of them chose the Vivitrol shot. It's difficult to start. It's a little bit challenging, and so it's really, I think, second line for a subset of people. Unfortunately, its appeal though is driven in part by stigma against the other medications. And so we actually often are addressing what's your motivation for taking this as opposed to these other 2. And it's usually because somebody in their family has said, don't take those 2. Those are replacing one addiction with another. Take this shot. And so we have to do a lot of education for families around the fact that taking a medication every day is not the same as addiction. It's different.
We have time for about one more question. Yes, sir.
So this is for, I guess, the entire panel, and I guess it relates to the healthcare system at large. So one of the biggest problems I think a lot of people recognize is the fragmentation of a lot of providers and of a lot of the, institutions that are related to our social determinants of health, including housing, incarceration. I know that there's a lot of organizations that are trying. The district program in particular, it's trying to integrate Medicaid into like community organizations that do work and hopefully have CBO partners that can help provide those ancillary services to meet those patient needs. However, I know people change, and that means they also change providers. And if we're not collaborating with, technically our competitors, are we really doing a disservice to our patients? So I guess what are the providers within your organizations trying to do to combat this fragmentation? And then in addition, what can, I guess, community members and patients do to push the providers to also, combat fragmentation?
Well, population management, which is, when we talk about value-based payment, what we're trying to do to have everybody integrated, certainly you're right. Certain people don't want that to happen. The decision had to come from the stakeholders, and you guys who go to votes and decide who should be your representative. We've been putting in front of them our findings. We had shown them the good results that we have when we work together, when we pay attention to the community as a whole, when the social determinants of we had diets now. We had plant-based diet. Thousands of people now involved in that, reduction in weight, the decrease in the medication. But you're right, they change, they switch, they go somewhere else. That we don't know if that continue, because while I'm not sure that I would like to have one payer only, because sometimes I don't want to see what I see in our countries, that the healthcare is managed by a government. I'm seeing in my own eyes when I deal with private institutions, believe it or not, I get better results when sometimes use a non-for-profit, because you have more transparency. We need to work on that. And I'm being called disruptor because of that, because I say those kind of things, but it's real. We've been doing that every day. Then we're trying to be sure that those non-for-profit organizations, CBOs, who work with us, are working really together for the benefit of the patients. We all have to survive in our environment that we are, in your jobs, protect the jobs, the unions, whatever you call it. But in healthcare, you have to put the patient first. And the patient first, and as a whole group, population management, and apply those things that are really working and helping, obviously, always keeping the human being in charge of the healthcare, and you allow them to make decisions with you and that relationship that you establish. But it will work only if the community understands this issue, and we need to educate. For that, we need resources to continue educating. We are requesting, for example, to extend the district a couple of more years, because we know the results. We know it's been worth it. We've been trained a different way. The training that we have now to do this trip didn't happen in the university. It's not there. That's not part of the discussion right now, what you learn about the human body as a whole, with all the tests that you do about how you handle these kind of changes?
You know, it's really funny to be talking about DISRIP. You know, it's such a technical yet so important thing that's happening in New York. And I bet you most people, raise your hand if you've heard of DISRIP before. All right, that's better. I guess maybe they're, yeah.
They're with me.
They're with you. But DISRIP is really important, and a big part of it was actually recognizing that we can spend healthcare dollars on things like housing or things that maybe historically weren't considered part of healthcare. Knowing now and learning from the DISRIP process that improves health outcomes. And I think that one of the biggest things with maybe fragmentation is this idea that, you know, healthcare dollars are spent on doctors and tests and medicines, but for many of my patients, supportive housing would probably be the single biggest intervention that would stabilize them and reduce their risk of reincarceration. And I think that DISRIP and other sort of efforts have helped us to broaden what is healthcare and what is care. And I think that's generally a good step to, you know, we're stepping slowly in the right direction.
All right. Okay. So we do have a question from our viewers online. Nick in New York asks, what is your opinion on the several trials happening in the United States which are targeting pharma companies that make the opioids? Is this part of the right path to curb this crisis?
Yes, this is definitely not my area of like expertise. I think that pharma has historically not always been transparent around the risks of opioids. They certainly aren't. They have motives sometimes toward profit that can sometimes conflict with, you know, with what's good for patients. I think personally that pharma is an easy target right now, and I think that some of the underlying issues that put people at risk of addiction and overdose are harder. And so a lot of effort is sort of, I don't know whether it's the right or wrong strategy, and I don't mean to weigh in on it, but it's certainly not the only approach, and it shouldn't be our only approach to addressing this problem. I think it's a narrow frame.
My concern, I don't really know enough about whether the law is a blunt instrument. I don't know if that's the right way to go. What frightens me from my experience in palliative care is that we're going to go back to the bad old days where people will not be able to get adequate opioids for a malignancy. And so I can remember early on in my practice in Chicago getting a call from a woman in tears saying, "Can you help me? I have widely metastatic breast cancer. My doctor will give me 6 Percocet a week so that I won't get addicted." And I mean, I would have been happy to pay for her treatment at the Betty Ford Center because she was dying from the breast cancer and was in terrible pain. I'm terrified we're going to go back to those days. And I mean, the OxyContin is a drug that has tremendous potential for abuse, but it's really helpful for somebody who has a severe pain problem to be able to take that medication and do well. It's the problem with medications get demonized, and it's not so much the medication is demonic, but some of the forces that have been involved in its abuse are. So my concern is that we don't want to stigmatize again the treatment of people at the end of life or with severe chronic pain problems for whom the use of opioid medications is a necessity.
That's just the pendulum is certainly swung, and there's a sort of quiet, not quiet, but there's a victim to all of this, which are chronic pain patients that have been on stable opioid regimens for a while. And I think we have to be careful that we, just like Father Sheehan said, that we're not demonizing a medication or a patient, but that we're treating people as human beings and addressing each person individually.
Thank you. And thank you all very much for your really thoughtful answers tonight and for sharing all of your experiences with us this evening. Join me in thanking our guests. Thank you all for being here this evening. Feel free to grab a drink or snack and come up and chat with our panelists for a moment.